This is one case study from Barad and Gleicher that kind of increased the interest in DHEA, but it was just a patient who had a dramatic improvement of ovarian reserve. She was 43 years old. She went through like 9 stimulations and 7 months of DHEA, and the first cycle, her peak estradiol was 1,200, and by cycle 8 it was 18,000, and they were afraid of ovarian hyperstimulation syndrome. And the 9th cycle, it was like 9,000. They retrieved 17 oocytes. So they got an increased response each time the longer they treated the patient with DHEA. A more recent study, but non-randomized, looking at DHEA in poor responders, also by the same group, that they thought that if DHEA increases oocyte yield and affects the early antral and pre-antral follicles, does it improve the ovarian reserve? Does it increase AMH? Does it increase the antral follicle count? And does it affect the egg quality? That was their question. So they looked at women over 40, and then they had women less than 40 with elevated FSH or low AMH level. And it was a retrospective cross-sectional and longitudinal study of 120 women with decreased ovarian reserve. So these women were treated for varying amounts of time, and some women were followed longer than others, and their AMHs were measured over time. But they stratified the patients based on age and based on their outcomes. So what they found was that there was no difference in any of the characteristics except based on age, because they stratified based on age, but that DHEA increased AMH. So in this graph, the blue are women less than 38 years of age, and the red are women over 38 years of age, and the black is kind of total. But what they found is that there was a trend towards increasing AMH in all groups of women with DHEA treatment, and it correlated with the number of days of treatment. And when they looked at pregnant women in red versus not pregnant women in blue, they found out that pregnant women had the highest increase in AMH. So it kind of ties together the theory. So their conclusions were that AMH levels improved with DHEA by 60%, and those who conceived had a better AMH response to DHEA. And they only followed 55 women over time, with 13 of those achieving a pregnancy or a 23% pregnancy rate. But again, all of Dr. Gleicher and Barad's studies were non-randomized. Now, they claim that it's very difficult to have randomized controlled trials in the poor responder group of patients because they are so desperate and they want the treatment and they don't want to be randomized to no treatment. And a lot of these women are paying out of pocket. So besides DHEA, aromatase inhibitors is another drug that increases the androgen production by blocking aromatase, and some other. Now, letrazole is the main one that we use in the US. And it works two ways. Centrally it works by releasing the HP axis negative feedback with the estrogen and increasing FSH and LH, kind of like Clomid. And it also works peripherally by increasing androgens peripherally, and they may affect FSH receptor expression and IGF-1 to promote folliculogenesis that we talked about. So in poor responders, you could use letrozole in different ways. We use it more sequential use, kind of either letrozole or Clomid. Letrozole we'll use 5 milligrams day 3 through 7, and then we'll start the gonadotropins, and we'll use an antagonist and trigger based on follicle size, and do this for IUI or IVF. There are 2 recent meta-analyses. The first one was Sunkara et al. In 2011, and this was in London, and they looked at all the studies of androgen supplementation, versus controls, and they wanted to look at clinical pregnancy rates and live birth rates and other parameters. And this is the meta-analysis looking at the outcome of clinical pregnancy rates in poor responders. They have 5 randomized controlled trials. 2 are with the transdermal testosterone. There's only 1 randomized controlled trial for using DHEA. And they found, even though there's a slight trend that favors treatment, but the results are not statistically significant in terms of affecting clinical pregnancy rates. This shows the outcome for number of oocytes retrieved, and there's no significant difference in the number of oocytes retrieved with androgen treatment versus the control group. And those are looking at the same studies. But when they just look at the randomized controlled trials, those 5 randomized controlled trials, that's all there are, and the total number of patients is very, is not so high. The WISER trial is the only DHEA randomized controlled trial, and WISER trials showed a significantly improved cumulative live birth rate in the DHEA group compared to a control group of 23% versus 4%, but there were only 33 women who underwent only like 51 cycles, and they looked at the cumulative birth rate instead of the live birth rate per cycle. And then there were 2 studies with transdermal testosterone of 163 patients. But they did see this a statistically significant increase in the live birth rate with the favoring androgen use. The meta-analysis looking at total gonadotropin consumption was statistically different, that patients who had androgens required lower gonadotropins. So the other recent meta-analysis looked at, most of those were the same studies, and they wanted to answer the question of, does administration of androgens increase the probability of pregnancy in poor responders? And their outcomes were the achievement of a clinical pregnancy rate per randomized patients. Now the testosterone transdermal, there were the 2 randomized, they only looked at the randomized controlled trials. Those both used between 10 and 12.5 milligrams, and they used it 15 to 21 days before ovarian stimulation. And they were both the gel. These studies used the gel. DHEA, there was only the 1 study that I talked about that used 25 milligrams 3 times a day. There were studies with letrazole, 5 milligrams a day for 5 days prior to gonadotropins. And they looked at studies using recombinant LH and HCG. And their results showed that only the transdermal testosterone showed some limited improvement of pregnancy rates, and the others showed no improvement, and that's most likely because the WISER study was not powered appropriately to really contribute. So our protocols, we're using a fair amount of DHEA now, but as you can see, there's just not a lot of evidence, and we use either the antagonist protocol or the microdose flare, and we will pre-treat them for 3 months. So this is just an example of our stimulation, and we trigger for poor responders at like 3 at 17 millimeters. This patient did not get pregnant. This patient had a microflare and did get pregnant. The microflare usually get more follicles than the antagonist protocol, but the pregnancy rates are very similar, and so you just try one or the other depending on what works, and this patient got pregnant. So we've just had a small series of the last like 30 patients, and we had a 29% clinical pregnancy rate with our DHEA patients. don't have that much experience with the testosterone. But there were no cancel cycle. These were patients who had been previously canceled and are poor responder, and then we do the DHEA. But again, this is not a study. So I'll summarize. This is Dr. Howard Jones with the first IVF test tube baby in the United States, Elizabeth Carr, who now has a child of her own, so the IVF works. And she had it naturally. And Dr. Howard Jones is turning 102 shortly, so he still comes to work every day. So in conclusion, poor responders, as everyone knows, is increasing in incidence. There's really lacking data, robust data of DHEA in randomized controlled trials. Most of them are small numbers and they're underpowered. And there's still so many people using it. A quarter of clinicians are using it because you just feel like you have to do something in this patient population. But it's very important to continue to try to do randomized controlled trials to really know what's going on. But it makes sense physiologically, as we discussed, that the androgens may increase the folliculogenesis. But still, there's that balance because in PCOS, too much androgens is bad, and you have the atresia. So DHEA may be better than testosterone in being more physiological levels of the androgens. But they do require a fair amount of pretreatment, and we need more meta-analyses, more randomized controlled studies. There is some evidence, as I showed you, for the transdermal testosterone in improving the live birth rates. Now, hopefully, this is just some of the things with ovarian aging. Mitochondrial DNA may be affected, so it would be interesting to look at DHEA to see if it reduces aneuploidy, possibly by affecting the mitochondrial DNA in these women. And I'm looking forward to the next talks on some of the nuclear transfer and some of the other new areas, exciting areas that may help our poor responders, because the androgens is not the whole story. But remember that quantity is not quality, so young women with low ovarian reserve should not be excluded from treatment, because a lot of these patients do get pregnant, because if you can get a few embryos, they're usually good quality and they can have good chances of pregnancy. So thank you. Any questions? I will entertain.
Thank you, Professor Stadtmauer.